Okay, the first two slides of the three are the basic assumptions that allow microeconomics to work. And the first one is that the product is homogeneous. So let's talk about that as it applies to healthcare. So much of healthcare, there's discussions about how to make knee replacement, how to market knee replacements. So knee replacements could be, an insurance company could send the person to India where they can be done less expensively for the insurance company. So it's a unit of care, as if every knee replacement is the same as every other one. But can you, I mean, I don't know how much experience you guys have with orthopedics, but every knee replacement is not the same as every other one. That's all I can tell you. If your patient is very short and obese, or has a leg length discrepancy, or has diabetes, or heart failure, it's not, everything changes for many, many, many things. And when people are talking about healthcare, product homogeneity is always ignored. And I'll just leave it at that. The people with heart failure and diabetes and technically difficult people, they aren't the ones that these insurance companies are going to commodify. They're going to send the simplest patients would be commodified in that direction, and underlying illness and comorbidity is typically ignored. On the medicine side, so that's kind of surgical units of care are treated as if they're homogeneous. On the medical side, when patients have long problem lists, which is what keeps me at work so late, it doesn't get twice as hard if a patient has both COPD and heart failure. It gets 4 times harder. It gets the problem every time you try to treat one with some new medication, it interferes with the other drugs or the other disease process. Things get really complicated the more diseases you keep adding. And those kinds of factors are very rarely factored in to the equation by health economists who sit at the Cato Institute and look at how they would like to change healthcare. So it's very much violated every single time and never considered. The second one on the list is free entry and exit of producers and consumers. So what would you guess about that? If you look at John Matthews' rural community that he talked about a day or two ago, what would you think? How free is the entry and exit of their patients?
Yeah, I see what you're saying. Yeah, I mean, it's kind of, it's obviously you're highlighting the flaws of why microeconomics doesn't work for healthcare, but I mean, there isn't free flow of people between health insurance plans. There isn't free flow of businesses because it's very difficult to start a health insurance company.
Yes, that's true. You need a fund balance, like we talked about. That's a lot of money. It's
Right.
very difficult to start one.
There's massive regulation, though not as much as there should be, but that's a different issue. Yeah, of course, like they're not true.
Okay, so that's so obvious. So the users of their clinic also often don't have a lot of money or transportation. They're going to go to the closest one for the most part, even if they're not overly excited about the care. So nobody's really that free. If you added a hospital across this, so in Vermont we have 14 hospitals, and they're all the obvious hospital for the community that surrounds it. And if you try to put a hospital across the street from the one that's already bankrupt in my community, they would go even more bankrupt. You would be duplicating. They'd all have to buy EKG machines, fire insurance, just everything, standards of care for training people about how to do CPR. The list is really long to put in a new hospital. It wouldn't be viable, and there's no freedom, of entry or exit in general. yeah, a doctor in a suburban community, a new doctor could come in and start a new practice. I get that, but it's not easy. It's a big effort. It's a time-consuming process if you wanted to do such a thing. But it can be done, but it's not an easy, very mobile process. So the next one is perfect mobility of factors of production. So that, for example, a hospital might want to hire a new doctor in a new specialty. The credentialing process often takes 2 months. So it's not, the mobility is slow in healthcare in many areas to get the expertise in a certain location. You know, to put in an operative suite that can do coronary bypass surgery is not a highly mobile event. It's a long planning process. Another one is that both producers and consumers are price takers. So that one we're going to talk about a lot with pharma. Like when you look at pharma companies, are they price takers or are they pretty free to set the price wherever they want to? And when that's the case, it suggests something very different from this perfect competition notion. And prices are set generally in fairly arbitrary ways, and there's very little competition. I have one example where that actually worked. A hospital I worked at a decade ago decided that the insurance companies have these fee schedules. And Cigna's was actually, and they're all different. So the hospital gets paid a different amount of money for the very same service by each insurer. And they just take the price. The hospital's basically sort of a price taker, not the insurance company. But anyway, Aetna went so low that the hospital or Cigna, I'm sorry, went so low, the hospital balked and they refused to do it. All the people in the community who had Cigna as their insurer, you can imagine their response. So it really created trouble, but they actually held the line. It was an unusual situation. But the market doesn't work that way. They're all, this is not free competition where the bottom one there, the large number, in a community, in Vermont, every community has one hospital really, and there's not a lot of competition going on. Like if I get chest pain right now, I'm getting taken to this hospital that's going bankrupt, whether I like it or not. That's where I'm heading. So, it is what it is. There's not a large number of producers and consumers in my community or in most any community. Urban areas come a little closer where you could often choose a hospital. There'll be 3 or 4. That's, a little closer. So anyway, this one, more assumptions. Everybody involved is a profit maximizer. You'd hope that that's not the case. I mean, if a doctor really wanted to profit maximize, they would get rid of all those patients who have a lot of comorbidity, morbidity, because those people take a really long time. And you get behind, and what you're billed for, it doesn't keep up with the amount of time you're spending on it. So fortunately, that's not the case. Again, I don't know. I think we should talk about what you want in the internship for the future, but I think you can make a general statement that the for-profit companies in healthcare are more assiduously working to make sure their bottom line is going to be favorable compared to not-for-profit providers of care. In the internship, I happen to have 2 people in the hospice industry. One of them is in the industry who's going to, I assume, defend or explain what they do. And then someone else is going to talk about for-profit hospice and what the strategies they use to make a profit. I wasn't going to do that in every industry that has for-profit sector, like for-profit hospitals. Do you want that for the internship, to talk about that topic of what for-profit companies sold publicly on Wall Street, how they behave compared to other companies, compared to not-for-profit companies? there's a lot of for-profit intrusion in healthcare in the United States. Dialysis, hospice, regular general hospitals. You know, if you're in Florida and I think Louisiana, there's a lot of, you know, you'll say Humana Atlanta or Humana, you know, Fort Lauderdale. You know, how do those hospitals behave differently from not-for-profit hospitals?
I was just thinking, Ashwin, feel free to jump in, but I was just thinking, I feel like we have a lot of coverage of sort of for-profit, nonprofit from a lot of different perspectives. So I don't know how valuable it would be to have somebody specifically explain for-profit hospice in particular. The general, I think we are getting a good general overview. Does anybody disagree with that?
What are you getting? I don't think you've gotten anything. What have you gotten?
I mean, we've just talked a lot about how for-profit and nonprofit sort of end up being, how for-profit ends up being a sort of a slightly worse version of than a nonprofit, where you do take some of the incentive to generate more profits out of it, but within healthcare, even with nonprofits, you're still within a system that has all the things that we've talked about in terms of fee for service and every other thing that makes it problematic in a system that isn't universal care.
I I like that analysis personally. What I'm getting at is that in but the effort on the part of the corporation, they're both corporate. They're both trying to do the best they can financially and leads to a lot of very similar behavior, which is what I hear you saying. I would make the argument that the for-profit ones are even more extreme in ditching unprofitable services, ditching things that are unprofitable. It's a matter of how extreme they'll they'll go to.
I think that perspective would be interesting. I mean, I haven't been part of some of the lectures, so it's hard for me to really speak to what you guys have heard so far. So if there is a lot of overlap, then yeah, obviously maybe it won't be worth it. But I think that in the future, for-profit healthcare systems will still be part of our system, even if we are able to institute a single-payer system, because they'll be be giving services outside of what's covered under a national system. So I think it would be interesting to see what their prerogatives are and how they view the system right now to get a better idea of how they're going to integrate into the future. But yeah,
I can say that you're right. In France, France has a sort of semi-single payer system, and they have a lot of for-profit hospitals that are organized in a for-profit manner. I, by the way, that's the only one, the hospice sector. I don't have anything else planned that I know of in this internship that specifically addresses what for-profit companies will do, how they use incentives. I don't know. You can think about it and let me know if you want it canceled. And that's about hospice. Ed Weisbart has a lecture
Learning about
organized.
hospice care would be helpful, for-profit hospice care, because I don't know the difference between that and like for-profit healthcare insurance companies. If they're the same, then I don't know if there's a lot to speak about, but I think it would be interesting personally.
Okay. Yeah, so then I retract my comment.
All right, I'll leave that day in. It's not, the only other thing is which I did not plan to do is that I know Ed Weisbart's a great lecturer. He has something prepared on something about the for-profit hospital sector. I did not ask him to do that. I have him for 2 other topics. I want him to do a speaker training for you. And he's also going to talk about profit and cost control in pharma. But this other talk, he can give a talk about for-profit hospitals. If you like him a lot and you want to hear that, I can do that, but I hadn't planned to. It was only hospice where that was planned, where you were going to hear kind of a pro and con on for-profit hospice.
I think one or the other would be great. I did really enjoy Dr. Weisbart's talk, um, but I think one lecture that specifically focuses on what the direct goals of a for-profit um, system is, and how they, what their prospective role will be in a single payer system is kind of what I'm hoping for. But also Liat's point about learning about how hospice specifically works is interesting. But in the grand scheme of things, I think in the future, hospice will probably fall under a single payer system, whereas some other parts of um, parts of healthcare may not and will be relegated to for-profit. So
Okay, so let's just finish these. So I'll leave that day in. No government regulation would be the ideal competitive structure. Obviously, that doesn't exist in healthcare. We are regulated. Producers don't select their consumers. This is like a really one in the insurance sector. This is really important because we went over those slides. Remember Aetna ditching 8 million customers? So they did select their customers and they got rid of the ones they didn't like because they were sick. So producers do select their customers to some extent. John Matthews Community Health Center over in Plainfield, Vermont is going to mostly take everybody who walks in. They kind of have to because part of the community health center program with federal funding. But other doctors, a good example is most suburban practices, especially in primary care throughout the entire country, blanket refuse Medicaid patients and only take uninsured people who pay at the time of service. So those providing goods often, providing a service often do select who they want there. Consumers are not manipulated by producers. So for example, you could say to, if you're encouraging someone to get a mammogram or to do an EKG that they want to do, say, oh, if you don't do this, you could die of breast cancer or coronary disease. So, the discrepancy in knowledge leads to the easy potential for manipulation, obviously. And then the final one is perfect knowledge of the product by producers and consumers. So in other words, if I'm treating a patient, one of us went to medical school and the other one did not. And so for a patient to decide that one surgeon is better than another surgeon, they're in a difficult position to do that for many, many reasons. The fact that one didn't go to medical school is high on the list, but there are other reasons too. Quality data are very difficult to come by in healthcare and very problematic. I'll just say that. That's a topic we could have a discussion about, how difficult it is to measure quality in general in healthcare. It's a big, big problem. Anyway, so that's it for for 2 of the 3 slides. The rest of it, I was going to look at some videos together and talk about how they could apply to healthcare. So let me try to do that. Now can you guys see this or no? Did you hear them?
we can only see your slides. I think you have to change your screen sharing option.
So Dr. Malek, if you just want to, when you click screen share, you can just click the first window. It should work. We can see it, but we can't hear anything.
What do I do?
There should be an option in the view options somewhere around there that says share audio as well.
Oh,
Another
where do I
option,
look?
another option would be if you want to send one of us the link, we can
Yeah.
share it.
Yeah,
and
that might be best.
Okay,
you can just put the link in the chat.
got it. There
Yeah.
are.
I can do the screen share.
It would be easier for me to just to forward this email to Leah. It's assuming I can get to it. How do
Here, I'm
I
just gonna
get
stop
rid
your
of?
sharing.
How do I get rid of the face? Oh, there we go. Okay. Did that have it? Maybe not. Did you get anything yet?
Yeah, I just got it.
It may not be there. It might be the second one I sent you to.
Yeah, I have 2 YouTube links. Which one do you want?
Yeah, the
The second
first of the two. First of
The
the
first.
two.
Okay. All right. All right, can you all see? Yeah. Okay. Ashwin, why is it not working?
In your screen sharing options, see if there's an option to share audio.
Do you see it, Ashwin?
I'm not seeing it.
Oh, right here. There you go. Oh, sorry. Just trying to find you for that.
I can't seem to get to the meeting controls. Why don't you just forward me the email?
All right, wait, or 1 second. Ashwin, here it is.
Oh, they're
Do
on
you see
there.
it now? Yeah.
Yeah, I got it. Which one is it?
The
It's
first of the two.
the NPR one, or no?
No. Oh, no, those are radio. Those are from the radio. Did you guys have a chance to listen to those?
Here, I found it. Wait.
I just read it. I didn't listen to it.
Wait. See, I just said share computer sound.
Give it a shot. Play it.
What's going on? This is weird. All right, Ashton, you wanna do screen share?
Yeah.
Okay, I'll stop.
Let's see.
Let's start by talking about something that most people take for granted.
Is it grocery stores? Is it The Simpsons? Is it GPS? Is it goldfish? Is it frogs? Oh, it's probably these strawberries, right?
Is it working?
Yeah.
No, I was going to say markets.
But strawberries are great.
Yeah, but where do you think strawberries came from?
The ground, the farmer, the market, the grocery store, the miracle of life.
Now look around you. Where did all that stuff come from? And who made it? And why? Well, the answer is simple, but it's underrated. It's markets. And for most of us, farms and factories and stores, but mainly it's just markets. Kind of strawberry now?
So a market is any place where buyers and sellers meet to exchange goods and services. The key to markets is the concept of voluntary exchange. That is that buyers and sellers willingly decide to make a transaction. Let's say you go to a farmer's market and you buy a box of strawberries for $3. You valued the box of strawberries more than the $3 you gave up to get it. The seller valued the $3 more than the box of strawberries. The transaction's a win-win because you got your strawberries and the farmer got his money. You both felt better off. That's voluntary exchange. This same process happens in the labor market. Say that instead of the farmer's market, you bought your strawberries at your local supermarket. The cashier voluntarily decided to work there. He values the $10 an hour he makes there more than he does sitting at home watching The Walking Dead. At the same time, the owner of the store values the labor of the cashier more than the $10 an hour she pays him. And so it goes on and on, all the way up the chain of production, from the driver that delivered the strawberries to the farmer that grew the strawberries to the tractor that the farmer purchased. The point is that markets are everywhere, and most are based on voluntary exchange.
The part of all this that most people take for granted is how efficient the system is. Competitive markets turn out to be pretty great about allocating or distributing our scarce resources towards their most efficient use. So if farmers produce like too many strawberries, then the price will fall as sellers try to sell them off. Lower prices means less profit to strawberry farmers, and those farmers will have an incentive to produce something else, like lettuce or Brussels sprouts. So if farmers don't produce enough strawberries, buyers will bid up the price, and the farmers will have an incentive to produce more, which then drives down the price. And that's like magic, except it's not. The information that markets generate to guide a distribution of resources is what economists call price signals. Markets also incentivize the production of high-quality products. If the strawberries are brown and nasty, then no one's going to want to buy them. And if the tractor's a piece of junk, the strawberry farmer is going to tell other farmers to buy some other tractor. Now, ideally, the eventual result of voluntary exchange is that sellers can't make themselves better off without producing something that makes buyers better off. Businesses, in particular large corporations, are often villainized for being greedy, heartless institutions that take advantage of consumers. But if markets are transparent and buyers are free to choose, then businesses will have a hard time taking advantage of people. Now, obviously, greed and deception happen in real life, and there are situations when consumers don't have a choice. But for the most part, if you really don't like the policies or practices of a particular company, then don't shop there. After all, in the free market, every dollar that is spent signals to producers what should be produced and how it should be produced.
We've established that prices and profit determine where resources should go. But where do prices come from? Who determines the price of my box of strawberries? To answer that, we're going to draw, get ready for it, supply and demand. Let's go to the runway.
There's only one thing you should learn in economics, it's supply and demand. Let's use the market for strawberries to help us understand this concept. Up here on the y-axis, we have the price of strawberries. Down here on the x-axis, we have the quantity of boxes of strawberries. Let's start by looking at buyers and how they respond to a change in price. If the price goes up for strawberries, then some buyers will go buy blueberries or they'll go on that all-bacon diet. The point is, they're going to buy less strawberries. And if the price goes down for strawberries, then people are going to buy more. And this is called the law of demand. When the price goes up, people buy less. When the price goes down, people buy more. On the graph, it's shown by a downward sloping demand curve. Now let's think about sellers, like the farmer in the farmer's market. If the price of strawberries goes up, then that farmer will make more profit, so he'll have an incentive to produce more strawberries. If the price goes down, then he's not going to want to produce strawberries. That's called the law of supply. And on the graph, it's shown by an upward sloping supply curve. Now let's put demand and supply together. If the price is really high at $10, then producers would like to produce a lot of strawberries, but consumers won't want to buy them. This mismatch is called a surplus. And if the price goes down for strawberries, let's say down to $1, then buyers want to buy a whole lot, but producers won't have an incentive and they'll produce very little. Again, you have a mismatch, but this one's called a shortage. And there's only one price where the quantity that buyers want to buy is exactly equal to the quantity sellers want to sell. And it's right here where supply equals demand. The price is called the equilibrium price, and quantity is called the equilibrium quantity.
Okay, sure your graph makes sense, but the price of strawberries isn't always $3. Sometimes it goes up to $6. And at Whole Foods, local, artisanally grown strawberries, the fancy strawberries, can cost upwards of $12. But I guess Whole Foods is a whole other world where price has nothing to do with realistic economics. We'll stick to normal strawberries. In fact, the prices for all sorts of stuff change all the time. External forces can shift both the supply and demand curves, changing the equilibrium price and quantity. For example, let's assume that this graph shows the demand and supply of strawberries in the summer. What happens in the winter? Will the change in weather affect buyers' demand or producers' supply? Spoiler alert, it's supply. Colder temperatures make it harder to grow strawberries. The result is the entire supply curve is going to shift to the left. This is because at all possible prices, there would be fewer strawberries produced. That's it. This graph is just a tool that economists and everyone else use to show the results of a change in a market. I know it seems complicated at first, but there are really only 4 things that can happen in a market. Supply can decrease, supply can increase, demand can decrease, or demand can increase. Some people might want to talk about a price being fair or right. Well, that all depends on your point of view. The buyer always considers a low price to be a very fair price, while the seller considers it unfair, and vice versa. In general, economists don't really like to push opinions about prices. Voluntary exchange suggests that the price is there for a reason. For example, assume the demand for strawberries inexplicably falls, so the demand curve shifts to the left and the equilibrium price and quantity fall. Farmers might go to the government for assistance, but most economists would argue there's no reason to bail them out. The market's spoken. Strawberries are so over. Furthermore, if the government helps the farmers by giving them a subsidy, it would be putting resources towards something that society doesn't value. That would be inefficient. Luckily, every reasonable person on Earth values strawberries, so they continue to get produced.
Stop it right
And the
there.
downside is the supply and demand model only applies to analyzing strawberries.
I want to pick up on her sentence, the statement she just made. If the government subsidizes something, then it makes it easier for the consumer to purchase it. And the economics of subsidies is basically the same as the economics of having health insurance. It's allowing you to purchase a product that if you had to pay the whole thing, the whole price, you wouldn't purchase it. It becomes less expensive for you because you have insurance. And this becomes sort of the crux of the argument around these high deductible plans, is that the logic is people are over consuming because they have insurance. So you should put them in a high deductible plan where they're paying every dollar, and that way they'll be more selectively consuming. And that's the logic. And I think they only have a couple minutes to go. Do you want to let them finish up, or do you want to? I think basically that's the concept of demand is what I was really getting at. Do you want to hear the other 2 minutes? They're pretty good, but you want to go ahead? Okay.
No, I'm just joking. It applies to all sorts of stuff. In fact, let's look at a market for a commodity known for its volatility, both because of its fluctuating prices and because sometimes it explodes. Gasoline. Now, when you see gas prices, they're moving all over the board. That's just demand and supply. For example, in 2014, the retail gas prices in the United States fell dramatically. Why? Well, it was demand and supply. The economies of both Europe and China weakened, which decreased the demand for gasoline, shifting the demand curve to the left. At the same time, new fracking technology and restored production of oil in Iraq and Libya caused the supply of gasoline to increase or shift to the right. The combination drove gas prices down by more than 40% per gallon. And that's it. Now you can tell all your friends you understand supply and demand. It's a big day for you. It's a big day.
So markets and supply and demand are awesome. But sometimes they're not awesome. For example, we don't want to use the market approach when it comes to firefighters. 911, what's your emergency?
My house is on fire. How much do you charge to put it out?
It'll be $10,000. What's your credit card number?
They're all melted.
Okay, that one's obvious, but what about the market for human organs? After all, there's a huge shortage and thousands of people die each year waiting for transplants. Should there be a competitive market for human kidneys? A free marketeer would say, sure, why not? If a donor wants $15,000 more than he wants his other kidney, why stop him?
Well, ethics. I mean, there's several problems that arise with an unregulated market for human kidneys. First is the moral question. Is it fair for a poor person who can't afford a kidney to die while a rich person lives? Well, probably no, not at all. Another problem results from the law of supply. When there's an increase in the price of kidneys, there's an incentive for people to steal and sell kidneys. In fact, the World Health Organization has stated payment for organs is likely to take unfair advantage of the poorest and most vulnerable groups, undermines altruistic donations, and leads to profiteering and human trafficking. I mean, all bad things. Now, that being said, why do 70% of American Economic Association members support some kind of payment for organ donors?
Well, it's because you can solve some of these problems with the market approach, but the market must be regulated. Often, family and friends are willing to donate a kidney, but they're not a match for the patient. Economists generally support creating kidney exchanges, where pairs of willing donors are matched with strangers that agree to donate to each other's loved ones. In both cases, the supply of donated kidneys would increase, which would alleviate some of the shortage. Like we've said before, free markets are awesome, but they can't solve all our problems. Sometimes they need to be regulated, and sometimes they should be avoided. So there you have what for most people is the start, and for many, the end of economics. Supply and demand. Economists and politicians often like to refer to the interaction of supply and demand as laws, and we've done that too. But be clear, it's not an absolute law like the law of gravity.
Well, as we've tried to point out here on Crash Course, economics is about human choices and their consequences. Even though supply and demand behave in a predictable way that we've seen in the models, we can't lose sight of the fact that both of them are reliant on humans acting as buyers and sellers.
Our actions influence supply and demand in a way that they can't influence gravity, no matter how much we might want to.
Whoa.
That's After Effects. And that's something to keep in mind when you hear us or anybody talking about economic laws. Thanks for watching. We'll see you next time.
Okay, so can you turn the thing over to me so I can share my screen?
You can just share.
Okay. Can you see this graph? This slide?
You're not sharing.
How about now?
Yes.
Okay, so this is my last slide. This is a slide you already saw. It's from the famous RAND study that was carried out from 1974 to 1982. And in the RAND study, they got the RAND Corporation out in California got funding for, I think, 6,000 people to be randomized to getting free care or two other insurance categories. One of them was 25% copay, and the other was 95% copay. And it actually was a high deductible plan beyond $5,000, what the current equivalent of $4,000 or so. They didn't have to pay anymore. So they had a catastrophic coverage too. But for the first $4,000 in current dollars, they paid, the 95% group paid everything, except for 5%. So here's pediatrics. For the green ones are age 0 to 4, and the brown ones are 5 to 13. So what they found was the people who got free care were much more likely to have a doctor visit. The percentage with no visit at all for very young children was a lot lower. It's a sort of a negative way to say they had more visits. So that study, when they looked at the utilization, this was what they found across the board. That the people who had really, really high quality coverage with essentially minimal copay, they used more health services. So what happened is when they looked at the difference in the types of health services the free care people were using more of compared to the people who had to pay a lot, they analyzed them from the point of view of like whether the visits are of public health significance. And they found that the people who had had to pay a lot and were using fewer services, they were just as likely to forego a visit that the public health people said really, really should have happened, as forego a visit that's more optional. So you could say an optional visit, I've had a stuffy nose for 2 days. So almost everybody would say, well, you know, go home and suffer. Why are you bothering the doctor for a stuffy nose for 2 days? You'll probably get better. As opposed to a visit to deal for a patient who had high blood pressure that's very difficult to control, which most doctors would say, well, that's a really useful visit. We're going to accomplish something for stroke prevention and, you know, all the benefits of treating high blood pressure. So anyway, what they found out was that it broke down around 50-50. It looked like a lot of the foregone visits were okay to forego, and others looked like they were really valuable visits that people didn't do. So with that kind of result, it's actually been used on all sides of the political spectrum. I have to say though that I have a friend who's actually on Medicaid, and she took her child who was 1 year old because a day or two before, he had had a zipper injury to his penis, and his penis was like stuck to, it was a bloody, ugly clot that was kind of stuck together, and it just looked horrible to her. And you know, she's a single parent, and she's looking at her kid like this, and she just took him to the ER because she was so upset. And that visit got denied by the insurer, saying that it wasn't urgent, it was a day old. No, the doctors never said it was infected. It wasn't. They said it wasn't infected. It was just kind of a clot. It was going to heal. So they denied the cost, which, you know how much emergency rooms charge. So, that's an example of an unnecessary visit. But the ethical or moral issue that I see from that is, you have an anxious parent. It's her son's penis. She's not an expert on penises, and like, let her have the damn visit. And what is the resource cost involved for somebody in the ER to look at the kid's penis and say, actually, it's okay, we'll cleanse it, this is what you should do, just go home, he'll be fine. Is that really cost a lot of money for the US healthcare system to give her some reassurance by looking at the kid's penis? And unnecessary visits are also low resource visits, typically. How much it provides, you'll hear, if you work in emergency rooms, you're going to hear people complain about Medicaid patients, because Medicaid patients typically have minimal copays or more often none, and they'll complain about them overusing healthcare services. But what makes ERs cost a lot is their ability to care for people with a brain bleed or a heart attack. Taking care of those unnecessary visits is trivial in the amount of cost. You could hire one extra nurse practitioner, and those visits are taken care of. So there's very little savings to be made from getting rid of marginally necessary pediatric visits. And what we know from the RAND study is that you're going to lose some really important visits, along with losing, the penis stuck together type visit, where just a parent is anxious about something, or, whatever. So I guess that's the point I wanted to make, is that, yeah, the incentives work, but the question is, do we have enough potential savings in the US healthcare system to want to deny a lot of necessary care and a lot of care that will allay people's anxiety? And I'll just leave it at that for that topic. One more thing on supply and demand. Did any of you have a chance to listen to those 2 radio segments that were on the list for today?
Yeah, I read both of them. You could read them or you could listen to them. So I just read them.
Yeah, well, this is kind of a trick question, but can you just briefly tell everybody what you heard and what your hit on it was?
Here, let me just put them in front of me so I have them fresh. Right. So coronavirus, the sort of you're talking about the Wild West coronavirus and the other one, right?
Yes, Ryan, I am.
So yeah, essentially just it was just this insane situation where the federal government declined to manage the market essentially and allocate PPE and ventilators and all that. And since they declined to intervene and kind of manage that process, and they actually encourage states to compete with each other to get those resources in just normal market conditions. So there were states literally bidding against each other for ventilators and PPE, massively increasing costs, sometimes tenfold. There were lots of examples of that. And this just bizarre situation where it was just really bad. It was just really, really bad where governors were trying to be more reasonable about it, but it was really hard because their constituencies were demanding, services and resources. So it was just a complete disaster. That was one of them. And the other one,
It was the same thing.
okay, yeah, same basic idea for both.
Yeah. It was the same thing. They were criticizing the federal government for putting the states in a position where they had a bidding war. But when you just saw this thing on supply and demand, bidding wars are supposed to be a good thing. So the trick question here is what's really going on is that the equilibrium price for an N95 mask is something like 75 to 95 cents, or a little something in that range. But the price was going up to $7 in this bidding war. But looking on the supply side, were the people who produce those masks, their costs did not go up. So they were still producing a mask that they should have been able to market at 75 cents. But now they were able to get $7 because of an abrupt increase in demand. So what really was going on, there was never a time for enough new companies to enter that market and start producing 10 times more masks, which is what we needed. So they never established an equilibrium price, and it was an example of where you needed a powerful purchaser to counter the extortionary activities of the companies that were now charging $7 for a mask. And I don't know if you caught more of it, was that the mask supply was bought out by a big Wall Street hedge firm that was now making this ridiculous amounts of profit by charging $7 or $10 for N95 masks. So it was really appalling, and it was just one example where you needed basically an authoritarian type government to just say, we are paying 85 cents for these masks, and that's it. You make a profit at 85 cents, you can continue to make your profit. We're not going to pay 25 cents. We're going to pay you 85, which is your usual price. Your cost of production did not go up. So it was just an obvious example where there should have been a very firm and dramatic government intervention in a non-equilibrium situation like that. So
and I mean, and even you don't even need an authoritarian government. I mean, you need the U.S. I think we all heard about this in the news, that the U.S. has the ability to implement some defense authorization,
yeah,
whatever it is, and can just say, guess this is what's going to happen. And it's rarely used, but Trump could have just done it, and he waffled for months.
Oh, I want to say more about that. So they actually used the free market argument. They said, we believe in markets. But what you've seen here is an emergency non-equilibrium market where new suppliers, couldn't jump in to produce 10 times more N95 masks that we needed. So it was destined to be a market failure because there wasn't time to create an equilibrium market. And it was a great distortion of microeconomics for them to make that statement that that we should just let it be as a free market, because it was going to be a extortionary market. And so it's just one of many examples. I don't want to get into this now, but when we talk about pharmaceutical pricing, you're going to have the same question. Do you, given what the pharmaceutical companies have been doing, should the government just step in? Which is actually what most of the European and Canadian governments have been doing. And do we, what are the effects of government taking a similar type of action in a non-emergency situation, but where prices are very high? So this will be a question that you'll want to think about. And as you're over, in a couple of weeks, we'll be talking about pharma, and that'll be a question that you might want to read a right-wing point of view about whether you want the U.S. government to negotiate on the behalf of Medicare.
I had a question. Is there any real free market in America nowadays? I mean, I feel like every commodity has some sort of government regulation.
I don't even think it's about America. I think the entire argument is a rhetorical one and not founded in reality. I mean, the entire video, I was just like, I don't think any of this is true. I think this is all just made up, like, after the fact justification. But,
Yeah, just the whole notion of transparency doesn't make any sense because, I mean, there is no transparency amongst corporations. You can't just go to one corporation and see that they have flawed business practices and go to another one. I mean, for instance, like Johnson & Johnson makes probably like 90% of all toothpaste. You can't just like find an ethical, I personally, this is like, my bias is now coming into play. I don't think there's such a thing as an ethical corporation. I think that's an oxymoron.
By the way, in a way, you're correct, Liat, what you said, that everybody has at least some laws they have to follow. So there are labor laws that theoretically don't allow you to discriminate, against anybody that you're not supposed to discriminate against, minorities or women or whatever. So everybody has some laws. Some markets work pretty well, like spring wheat, winter wheat, when the commodity is homogeneous, everybody involved is a price taker. There's a large number of suppliers and purchasers. So a lot of times agricultural commodities follow those free market structures better. But I think mostly I agree with what Liat said, that most markets become distorted through monopolistic activities. So in other words, can there really be fair market competition between Walmart and some little downtown business that's trying to compete with them? Or between Amazon and some small bookseller? It's, there's crony capitalism and there's just monopoly and size advantages that lead to market concentration. So there's very few commodities that work quite as well as spring wheat. Definitely that's true. There's regulation on spring wheat. You can only have a certain percentage of rat excrement and rodent excrement in spring wheat. And if they sample it and it's too high, then they have to withdraw that sample. Anyway, but there's less regulation in spring wheat than on a lot of other things. So I'd like to take a break.
Spring wheat? I'm just curious.
What's that?
What is spring wheat?
There's in the Great Plains of the United States, North Dakota down to Oklahoma, they grow a lot of wheat. And in the southern states, the wheat grows through the winter. They plant it in November or so, or December, and then it grows through the winter slowly and it's harvested in the spring. I don't know. There's two crops, the northern crop and the southern crop, and one is winter wheat and the other spring wheat. So these are commodities, agricultural commodities to get into the wheat market. There's a corn market, there's corn markets too. Anyway, so I wanted to talk about market failure when we get back. It should take about 20 minutes.
So 10-minute break?
You want to take a break? Okay.
10 minutes?
Okay, 10 minutes. That'll be 11:26. Malek, you gotta go out, buddy. minutes. Okay. Should we restart? Okay. All right,
Yeah.
so before we look at the other video from youth crash course, I just wanted to say, to review what we've already covered. One of them is the difference between need and demand. And demand is would be the number of pediatric visits under different conditions. One is co-insurance, the other would be no insurance at all. And you can see that the market actually has the effect of, if you face more prices, you get less demand, which goes along with microeconomic theory. But then there's this notion of need. And the notion of need is kind of a elitist, is criticized by the political right as being elitist. That you're saying, I need this visit, but I know my body, who are you to tell me, you supposed expert? So who are you to tell me to wear a mask in the coronavirus, in the midst of a pandemic? Like, you're the supposed expert. So for example, there's a huge revolt against Tony Fauci, who's working on the pandemic. There's literally a campaign. He's had death threats multiple times. And he represents this elitist notion of need, that there's some knowledge base that has some expert saying that, children need visits, that my kid's all right, he doesn't need that, he doesn't need a vaccine. So this is a big quandary in public health of how to get people who smoke to stop smoking. Like, for me to say to a patient, you really need to quit smoking because your lungs are already pretty bad to start at this point, after the 30 years you've already put in with those cigarettes. So the idea that the need to do something tends to be elitist and resisted in ideological terms by the political right wing, but in just more impulsive and closed-minded terms by other people. But on the other hand, when experts are incorrect about something, there's a lot of inherent resentment, and then sometimes people pose as experts. So this is a big conflict that goes on in the healthcare sector about need versus demand. So I guess that's the main point. One of the reasons I wanted to have a session on microeconomics was so that if you are speaking to a group with a lot of people who believe in markets as, the Holy Grail, I think it's nice if you develop for yourself 3 or 4 examples that you can say right off the bat, because you're ready with them, of examples of why markets work very poorly. And I think one of them is pharmaceutical prices. One of them is hospital prices, since hospitals are, you could argue that they're natural regional monopolies or local monopolies. So for example, our regional monopoly for tertiary care is Dartmouth. Dartmouth is way closer than any tertiary care center, so people go to Dartmouth. And in New Orleans, you've probably got a few hospitals that provide tertiary care, and they can't have competitors. The cost of entering that market to put in 6 more tertiary care hospitals would be ridiculous. So the question is, how do you keep their prices? How do you best make it so that people can afford the tertiary hospital care provided at your hospitals in New Orleans or at Dartmouth? So I think if you can come up with 3 or 4 examples to respond to someone who somehow says that we should have, no government regulation, I think that's a useful thing to do going into a talk. Anyway, so I want to talk to go through the video on the video that's left. It's either on monopoly or market failure, which kind of is related in healthcare. So can you go ahead and show the other one?
Somebody's got it, Ashwin or whoever.
Yeah, I'm working on it. I'm not seeing the video on the syllabus. Leah, could you forward me that email?
I don't think I can because I don't think I have your email address. At least.
I can do it. I figured out why my sound wasn't working.
Okay, cool.
It's a nice refrigerator, Ashwin.
To be you is refreshing. Batiste Dry Shampoo.
Welcome to Crash Course Economics. My name is Jacob Clifford.
And I'm Adrienne Hill. Today we're going to talk about monopolies, which are terrible, illegal, and only serve to exploit helpless consumers, except when they're delivering essential services that competitive free markets kind of fail to deliver.
So are monopolies good or bad or
both?
When some people hear the word capitalist, they picture the robber barons of the 19th century. Cutthroat monopolists like Andrew Carnegie, J.P. Morgan, and John D. Rockefeller. They dominated industries like oil, railroads, banking, and steel, and would do anything to crush their competitors. After all, in Rockefeller's words, the growth of a large business is merely a survival of the fittest. Now, it's true, market economists love competition, but monopolies are the antithesis of competition. In most cases, economists want to prevent monopolies, not celebrate them. Let's go to the thought bubble.
A pure monopoly is a market controlled by one seller with a good or service that has no close substitutes. But the true power of a monopoly comes from its ability to keep competitors out of the market. Monopolies are able to erect obstacles that economists call barriers to entry. If a company starts offering a brand new product in a market with low barriers, they won't maintain market power for very long. Take gourmet food trucks. In the last decade, gourmet cooks started moving into the street food business, competing in a market historically associated with lower quality options like hot dog vendors. These food trucks were a hit. Demand was high and the barriers to entry were relatively low, so more and more competitors jumped in. Now, food trucks are kind of everywhere. And that's exactly how capitalism is supposed to work. People wanted more street food options, and profit-seeking entrepreneurs gave them what they wanted. Incentives and competition made society better off. But imagine a city where there are limited numbers of licenses for food trucks. And I own all of them for my fleet of artisanal macaroni and cheese trucks. I also know the mayor, since he's a big fan of artisanal macaroni and cheese. If I can convince the mayor to ban traditional pushcart food vendors with their shawarma and their bacon-wrapped hot dogs, I'll have a monopoly on street food. I'm not increasing my profit by producing more stuff. I've influenced government regulations in such a way that anyone who's hungry but doesn't want to enter a building has to buy food from me. This is sometimes called crony capitalism, and it's a big reason many economists call for government transparency and accountability.
Thanks, Thought Bubble. Companies don't have to have a literal monopoly to exercise monopoly power. When a single company has a huge market share in its industry, like Google does for search, they wield a lot of the same power that a pure monopoly would. Now, when a few firms control a large majority of market share, it's called an oligopoly. The market for mobile device operating systems is a good example, with Google's Android and Apple's iOS. The point is that one company doesn't need to have 100% of market shares to operate like a monopoly. In the example of the anti-food truck ordinance, the barrier to entry was government regulation. But what are some other ways companies maintain large market shares? Well, there's also control of resources. Like De Beers once had 90% market share in diamonds because they controlled the world's diamond mines. Another barrier is high startup costs. You might want to build a nuclear power plant to compete with your local power company, but you need a whole lot of money to get in the game.
Monopolies can restrict output and charge higher prices without worrying about competitors. This is why most economists support antitrust laws that promote competition and outlaw anti-competitive tactics. They're called antitrust laws because monopolies used to be called trusts. In 1890, the U.S. passed the Sherman Act, named for Senator John Sherman. Sherman argued, if we will not endure a king as a political power, we should not endure a king over the production, transportation, and sale of any of the necessaries of life. The Sherman Act outlaws any monopolization or attempted monopolization. Court rulings and later laws gave the Department of Justice and the Federal Trade Commission greater authority to prevent monopolies. If the Coca-Cola Company wanted to purchase PepsiCo, it'd be a tough regulatory sell. In the U.S., mergers and acquisitions need to be approved by the government agencies. Economists call the act of buying companies that produce similar products horizontal integration. Like AT&T tried to buy T-Mobile, but failed because regulators believed the new company would control too big a share of the wireless communications market. Vertical integration, on the other hand, is when a company directly owns or controls its supply chain. For example, in the 1920s, the Ford Motor Company owned much of the entire supply chain needed to make cars. It owned iron and coal mines, and it made its own steel, glass, tires, and even paper in the massive River Rouge factory complex in Michigan. Vertical integration's complicated, and it's not always illegal. When a company just expands its business to insource part of its supply chain, that's usually not subject to antitrust regulation. Companies can run into some trouble when they try to vertically integrate via mergers. Antitrust regulations can also prevent companies from making anti-competitive deals with their suppliers. In the late 1990s, Microsoft was accused of pressuring PC manufacturers to pre-install Microsoft's web browser, Internet Explorer, and exclude their main browser competitor, Netscape. Regulators busted them and almost busted up the company. Even Toys R Us, it's gotten in trouble for conspiring with toy suppliers like Hasbro and Mattel to stop the manufacturers from selling certain toys to other stores. So monopolies and monopolistic behavior are bad, right? Well, it turns out sometimes they're useful. Look at patents. A patent grants an inventor exclusive rights to profit from a specific product or process. In the US, it's actually written into the Constitution. Patents and other intellectual property rights encourage innovation. Pharmaceutical companies spend billions of dollars each year developing drugs, and patents allow them to recover those research and development costs and ideally earn profit. A patent essentially guarantees their right to be a monopoly, but not forever. After a certain amount of time, usually about 20 years, a patent expires, which lowers the barriers to entry. Competition moves in, prices fall, and companies look for something new to patent. Intellectual property law and patents are really complex. And Stan, he's actually done a whole series about them.
Natural monopolies are a special situation where it's more cost-effective to have one large producer rather than several small competing firms. The best examples are public utilities in markets like electricity, water, natural gas, and sewage. They may be privately owned or publicly owned, but either way, they remain a monopoly because the government limits competition. I mean, if there were 3 competing electric companies in one city, that would mean building 3 different power plants and running 3 sets of power lines through the streets. The result would be higher costs. So in this case, it's cheaper to have one electric company because they have economies of scale. The monopoly can still raise prices and abuse its power, so the government often regulates prices and fees. Now, of course, there are debates about when the government should intervene and which markets justify natural monopolies. Nike has about 90% market share in basketball shoes, but it's not a natural monopoly. It's a non-coercive monopoly. There are plenty of other shoe companies and people aren't forced to buy Nike shoes. So there's no reason for the government to get involved. But that's not always the case. Up to the 1970s, AT&T was given natural monopoly status, which gave it nearly complete control in the telephone industry. In 1974, an antitrust lawsuit was filed by the Department of Justice, and the end result was the largest corporate breakup in American history. AT&T dissolved into 7 regional telephone companies, and other companies like Sprint and MCI quickly jumped into the market. This process is called deregulation, and it's happened in all sorts of markets, from delivering the mail to airlines.
So let's step back here. Why are we so worried about monopolies? Well, a lot of this has to do with pricing. For one, monopolies can charge more for their products than they could if the market was competitive. They can also engage in a practice called price discrimination. Price discrimination is the practice of charging different consumers different prices for exactly the same product. In fact, the earliest regulation of railroads came about because they were engaged in price discrimination. They charged different rates to haul freight. This gave an advantage to companies that ship more freight and helped to force smaller producers out of business, creating even more monopoly power in the economy. But price discrimination isn't just for monopolies, and it's not always illegal. To pull off price discrimination, a business needs to be able to segregate the market based on consumers' willingness to pay. The airline industry does this using time, charging those that book early less than those that book late. A price-sensitive student might only be able to pay $200, so she books a seat weeks or months in advance. A time-sensitive businesswoman that needs to be at a board meeting tomorrow might be willing to pay $800 for the same type of seat on the same flight. The point is, charging a single price wouldn't generate as much profit as charging different prices. Price discrimination happens more often than you might think. Discounts based on age or occupation are good example. Price discrimination works best when firms have a large share of market power. If there were hundreds of airlines, it's unlikely that any one of them could price discriminate without losing customers. Like a lot of things we look at here in Crash Course, monopolies and pricing are complicated. Generally, competition is a good thing, except when it isn't. Thanks for watching. We'll see you next week. Crash Course Economics is made with the help of all these fine people. You can support Crash Course at Patreon.
Yeah, so the question I have is that we have in healthcare is where we want monopolies. And just to be precise, a single payer is called a monopsony. A single producer is called a monopoly. So because all the rural hospitals in my region and in regions throughout the United States are all going bankrupt or are close to it, there's been regionalization, buyouts basically by the tertiary care centers, which usually can make a profit. So we have, where I live, we have a regional monopoly that's controlled by Dartmouth. And in Burlington, they have a regional monopoly controlled by the University Hospital there. And I'm sure that you see them wherever you live, because that's what's going on in the US. That we basically have, if you want to get health care in the region of southeastern Vermont, your money's gonna go to Dartmouth. So what do we do to control the amount of money that Dartmouth is charging? And when people argue to have an unlimited number of insurance companies, that we should deregulate insurance companies and allow insurance companies from Montana and Washington, D.C. and all over the country to sell insurance here in Vermont, what kind of market power would having 100 insurance companies have vis-a-vis the regional monopoly here?
Could you say your question one more time? I'm sorry.
Yeah, there are people on the political right in Vermont and across the country want to have deregulation of health insurance companies so that they can do whatever they want to do and just sell their product. Buy my insurance companies. And the other insurance companies say, no, buy mine. But they're going to be negotiating against a monopoly, Dartmouth, if they want to sell their product in southeastern Vermont or southwestern New Hampshire. So the question is, does having multiple insurance companies negotiating against that monopoly of provider of healthcare services, what do you think that's going to do to prices when Dartmouth has control over the market for this whole region of the Upper Valley, the Connecticut River?
I mean, in the current system, in the healthcare market as it stands today, increased competition doesn't lower costs. We know that. So are you asking a different question?
Well, defend your statement with one or two reasons.
Well, I mean, first, it's just been demonstrated that it just doesn't work. But I think
point.
the reasons for that are health insurers sort of have a baseline level of cost because of all the things associated with running a health insurance company. And so there is a floor under which people just aren't going to enter. And that, and there are also really large barriers to entry. So, I mean, increasing competition, there's perhaps a margin where you could have a little bit of cost reduction, but at the end of the day, the market is at this point as efficient as it can be in a competitive market. That's the issue, is that if you have a non-competitive market with a single payer, you get much more efficiency in healthcare, and in many situations. But healthcare is one of those ones where it's useful because there's lives on the line.
I mean, I think if you want to respond in more economic terms, you should say something about the costs that insurance companies, you got it that. You said the internal costs of insurance companies. And remember, we got that list from Alexa of all the different divisions within Blue Cross,
Sure.
All the little departments. They all have to do those things. I'm assuming they're all necessary. So there's all these things they have to do that cost money. And then if you're having 10 insurance companies, they're all doing those things. They have to spend all that money too. So there's a lot of internal costs. And then the costs they inflict on the providers to contend with them. All different regulations, very complicated. So it tends to raise prices to have forcing the doctors to contend with all these different regulations. And actually in Vermont, I have to say that if some company from Washington or DC or Montana tried to sell insurance here, we may not trust that this insurance company from Montana even has a fund balance in case they have a bad year. So we might not even accept our insurance. We may force the patient to pay right up front, and then they can contend with our insurance company. That's actually how it worked in the 1950s. People paid up front. And you then sent your bill to the insurance company hoping they would pay. So there's a lot of issues having multiple insurance companies, but they add a lot of cost to the system. The other argument, though, is the simple economic one, is you've got a monopoly in a position to charge whatever they want. The only way to force them to drive down their prices is to have a monopsony countering them, or some, two or at least a group of payers, so that you have a monopoly against a monopsony, and that starts to be a fairer competition to get the price down. Monopoly tends to raise the price, the monopsony tends to drive the price down. Monopsony means single payer.
But I mean, the reason why health insurers are expensive is because they spend so much money figuring out how to not pay for stuff, essentially. When we're talking about administration, what we're referring to really is teams of people whose job it is to avoid paying money, to develop creative tax schemes, it's just all about money retention, because the amount of money they're going to get paid for services is set by the government, by Medicare, with some variability. But ultimately, the amount of money they're going to make is within a range going to be fairly consistent. So what they're doing is avoiding stuff. And so the way that you reduce their costs is by saying you can't avoid stuff anymore. And there's lots of ways you can do it. You can do it with a monopsony, just by saying this is the new price scheme. Get used to it. And the only way they can respond to that is by saying, okay, we'll get rid of some of our administrators that are make us less money because we have less money. I mean, I don't know if I'm 100% right about it, but to me, it seems like that's sort of how this plays out.
You're saying they don't have much ability to reduce their internal costs because they have to have all those departments. So what they're going to actually do is try to reduce the quantity of services. by denying care for some of those services.
Almost. What I'm saying is that they are going to, if you introduce a monopsony or you introduce more regulation, what they're going to have to do is cut administrative staff ultimately, because that's what their additional expenditure is above and beyond the fees that can be charged. So you're going to lose administrators. They can also cut services, but there's probably a floor there too. Because if you have a monopsony, you're going to assume that service is going to provide a reasonable level of care. So they can't get substantially below that reasonable level of care, because then no one will pick up their insurance, will pick up that insurance. So you're squishing the market, and the fat that comes out can only really be the administration, because that's where the extra cost is. I think that's my argument.
What they actually spend most of their strategic planning doing is picking out their customers.
Right,
That's actually their best strategy.
Right, the people who make those choices, those are the additional cost administrators. That's what I'm saying. Those are the people that would have to go.
Right, and those are the last people to be fired, because that's how they can actually do better in the market, is by getting rid of customers that are expensive. Through selective marketing, in Aetna's case, they just ditched them. They just said, we're not going with it, or we're gonna, put your check. I actually knew somebody in California who their insurance plan, the cost of their insurance plan went up to $13,000 per quarter for a single individual coverage, $52,000 a year, a single insurance coverage. This was 20 years ago. And that was like an asterisk. He couldn't believe it. He looked at it and he thought it was a mistake. But basically they were saying they didn't want him or his company to buy their insurance. So he was being ditched. That's really what was happening. Anyway, so that the concept is there a natural monopsony, or if in the health insurance industry? And I would argue that due to the high costs of insurance company administration and the doctors having to contend with that, and the inability of multiple insurance companies to drive down pharmaceutical costs because they're so divided up and they don't have the expertise to do it. I mean, those start to be the arguments for a more cost-effective healthcare system that I would make. But anyway, to summarize this, I think you guys preparing for talks that you're going to give to potentially conservative audiences, I think you should have some examples that you can articulate quickly and effectively. And I think if you spent an hour trying to do that, you would be able to come up with examples to be able to handle that question. And that question most of the other questions you'll get asked when you give a talk will be easier than that one. So that's one of the harder ones, and I think it's worth preparing for. And I think that the kinds of things you heard today give you a sufficient, this is kind of all you need. You don't need to get much further into microeconomics to begin to argue against them on their own terms by applying all these distortions in microeconomics as they're applied day to day. They're all distorted, and they all ultimately fail due to the distortions. One of them being need for care. The final thing I wanted to talk about was externalities. I'm going to send you, maybe we can talk about this on another day. I was going to send you another one of the crash course things on market failure that also talks about externalities. And when you're watching that, think about whether you want to be willing to have a country where we provide care to undocumented workers. So that's like a question that we'll look at in when you're looking at externalities in healthcare. Do you know what externality, the word, means as it's applied in economics?
Yes.
Go ahead, tell everybody.
Externality is just a cost, essentially, or an effect that's not built into the price tag. So
exactly.
If you're mining for oil and you ruin the nearby stream, but the repair of that stream isn't factored into the cost of selling that oil, then that's an externality.
Exactly. So I'll email you the link to the crash course, the 10-minute crash course thing that talks about that and market failure. And we can talk about that on another day.